Right, well, thank you for having me. I've gone a little bit around the world, but this is quite nice to be here. I quite enjoy coming back to the UK. So this is what I've been used to. So sunny skies, although I was expecting rain and it hasn't really happened yet, although I have been told.
You won't be disappointed.
Yeah, it's going to be coming. But yes, so in Brisbane we've got lovely environment, but similar groups of people with Parkinson's disease. Our environments might be slightly different, but I think a lot of the issues that are important to people with Parkinson's disease, it doesn't matter where you are in the world. This is the university campus that I'm from, so it's what we call a sandstone university, so one of the older universities in Australia. So, but what I'm wanting to talk to you about today, and just ask questions throughout if you want to, or if you want to ask at the end, that's fine, so I don't mind, just ask as you go along. So the inability to walk for doing things other than just walking has been reported by people with Parkinson's disease as one of the most debilitating elements of the disease. So we've done a couple of studies trying to understand community walking in people with Parkinson's disease. And so this was as a result of focus groups with people with Parkinson's disease. And people with Parkinson's disease in Australia report that walking outside, as you can expect, is really important for their independence. And they identified many barriers to getting out and about or to their community walking. And we're talking about walking, we talk about it walking beyond the garden gate. So in the garden, around the home, it's considered home walking. In particular, as you can expect, they tend to report environmental issues to be more important than personal, which tends to be quite common in older people. You know, oh, it's the footpath, it's not me. I'm not the one with the problem, it's everything else around me. So that's not uncommon. But in particular, crowds are quite an issue going out and about, so there may be barriers to people getting out and about. And other attention-demanding situations where they have to think of other things at the same time. We followed that up with a survey of a couple of hundred people with Parkinson's disease and found that over half, or 63%, reported that when they're out in the community walking, they're generally doing something else at the same time, whether it's carrying something or thinking at the same time. They say that focusing on their steps when they're out and about helps them walk better. They say that they have to concentrate harder to walk in the community than when they're at home. And importantly, almost half said that I would walk in the community more if I could manage distractions better. So, that's okay, come in. So it's just sort of highlighting that if they could, if they could manage distractions better, almost half of people think that they might get out and about more. We've also had a look at falls in the community in people with Parkinson's disease. And so this was part of a larger study where we prospectively followed up nearly 200 people with Parkinson's disease over 14 months. And when we have a look at their falls, 62% of people fell. But look at the number of falls. 1,835 falls were reported in that 14-month period. Of all those falls, 17% occurred when they were in the community. But interestingly, over half of the people who fell reported at least one fall in the community. So they're not just falling at home. So people are falling when they're out and about as well as when they're in the home. So if we looked at those people who only fell in the community, and so they hadn't had a home fall, they had a shorter time since diagnosis and they had a less severe Hoehn and Yahr score. So that's kind of what you would probably think because you're thinking those people are getting out and about more. They had a lower UPDRS motor and ADL scores. They had a history of fewer falls, but 50% had had a past fall. In comparison to those who had fallen both in the community and at home, had a history, 64% had a history of at least one fall, and those who were home only, 84% had a history of falls. And they fell less frequently than those who were either just falling at home or home and community. So there's a certain type of person we think who is falling in the community. When we analysed the falls, so what we did, so they rang up a falls hotline and described their fall. And so then a couple of us looked at the transcripts and the information that was written down about the circumstances of the fall. And then we looked at seeing, well, what environmental aspects might be contributing to the fall given the circumstance. And when we had a look at these outdoor falls, the top ones that differed them from falls in the home were challenging terrains, high attention demands, they were falling in busy or cluttered areas, and they were undertaking tasks that needed speed. So these are some of the issues to consider in people who are out and about in the community. These were circumstances that you may need to talk to patients who have Parkinson's disease that might put them at greater risk of falling. So challenging terrains, which that varied, it was going down off a step. It wasn't necessarily just uneven terrain. It might have been slopes. High attention demands, that was generally they were doing something else at the same time. So they reported, I was talking to my daughter as I was carrying something and I walked outside and I missed a step and fell. If they're in a busy or cluttered area, and if they were rushing. So people report community falls when they're dual tasking. Situations requiring high attention demand do seem to be barriers for people to get out and about, and people say that they would get out and about in the community more if they could handle distractions better. And other people have demonstrated that dual tasking deficits can predict falls in people with Parkinson's disease. So with all of those together, it makes us think, can we improve people with Parkinson's disease in their ability to undertake both a cognitive and motor task together? Now, let's see if this works. So you will know clinically that when people with Parkinson's disease walk and do a second task at the same time, you show deficits in their gait. So whether it's reduced step length, speed, increased variability of gait. Let's see if this will work. A video. So this is a man who's doing a timed up and go test. So on this left hand side, he'll just be doing it straight without a second task. And on the right hand side, he's doing counting backwards by threes at the same time. So you can see, I tried to time them around the same time. He's taking a lot longer on the right hand side, taking much shorter steps, both as you go along and on the turn. So that's quite typical. People also demonstrate more freezing episodes when they're doing a second task, if they're prone to freezing. Let's see if this will advance. So as a result, traditionally people with Parkinson's disease have been told to avoid dual tasking. So to manage yourself so that you don't have to carry things at the same time. Don't do a second thing at the same time. But we know that life is not really like that. So real life is you're walking along, you're carrying, you're talking to someone else, you're thinking about what you're going to next. So to prepare people for maintaining their life in the community, they really have to be able to multitask. So there have been a few studies that have looked at dual tasking in people with Parkinson's disease and seeing if we can improve that. So ranging from smaller feasibility studies with a few people, more recent ones showing some short-term improvements in when they're doing dual task training in maybe their ability to do a cognitive task while walking, but not necessarily improving their gait performance. And so there's a need for more studies that are larger and more comprehensive to look at training dual tasking in people with Parkinson's disease. So to help with our understanding of how we should train, we need to have a look at a few guiding principles. So we've done a few incremental studies looking at some of these guiding principles. So the first is looking at specificity of training. So we need to have specificity of practice to maximise our motor learning. So you need to be, you don't want to be training reactive balance control if you're trying to get anticipatory control to improve. So that's all well and good, but we need to maximise our training time, and we'd like to try and see if we can transfer people's ability to improve one type of training to another. So transferring, so if you train one skill, does it lead to improvements in another related skill, is something that people with Parkinson's disease often find difficult because it requires some executive function which they tend to have some difficulties with, say like updating their task set information and adapting to change. So we wanted to see if people with Parkinson's disease could transfer the ability to be trained in one type of task, and can they show similar improvements in other types of tasks. So what we did a pre-post study with people with Parkinson's disease and had them walking along up and down 50-metre paths and did a 20-minute training session. And what we did, we trained them to do second tasks at the same time. So counting backwards by threes, sorry, not by threes, that's our assessment, so counting tasks, as well as thinking of words beginning with certain letters. So that's what we trained, and we assessed them pre and post on different types of tasks. So we looked at, this is say their stride length for gait only, for doing a motor task, so two different, a simple and a complex motor task. So this is carrying a tray versus transferring coins between pockets that we had. And then listening tasks, so discriminating tones, high and low pitched tones, and a visuospatial task, so determining whether things were the same or different in a visuospatial task. So when we looked at them after they trained in this type of task, we found that there were significant improvements in gait in most of those different types of tasks. All but the very simple motor tasks showed a significant improvement in stride length. So it looked like, regardless of the type of task or difficulty, there was an improvement in stride length. So there was some transference of learning, which was quite good because we did a working memory task and it transferred to improving their ability to dual task when, say, doing a complex motor task. So it showed that people with Parkinson's disease had some ability to learn and do that set shifting. Interestingly, when we had a look at their gait speed, so before we were training their ability to take big steps as they were doing the second task. So that's what we were telling them to do. So big steps as we're doing the second task. Gait speed, we weren't concentrating on gait speed during the dual task training. So if we have a look at how that improved over time, it didn't improve as frequently over time. So yes, it showed some improvement in the task that was trained, but only in a couple of other tasks as well. So there was less transfer of dual task ability from the trained to the untrained added tasks when other types of gait parameters. So it shows that it's important as to what you're concentrating on with the gait side of things. So the transfer of training was really, or the specificity was really important in the type or what you're concentrating on in their gait. So it also shows that, so you might not need to train every different type of added task to show some improvements. That's the first one. And then the second key point is if they have deficits in, when you do, say, a timed up and go test with second task, and so one person might reduce in step length, another person, the step length might not be too bad, but it's overall velocity that reduces. Concentrate on that gait parameter that you want to improve most when you're dual tasking, rather than trying to concentrate on multiple parameters. So that was one element of training, task specificity. Another element is instructional set. So what you're thinking of or what you're prioritising, because you've got two different tasks there that you're doing. So in training, you could do what we call fixed priority training, where you have equal attention to both tasks, or variable priority training, where you switch between the two. And so we know to improve motor learning, it's ideal to do some variable priority training. So variable priority might be that you're thinking of your second task, which might be talking, then the next pass or the next time you're doing it, you're concentrating on what you're doing, so you're concentrating on your gait, then you might switch back to concentrating on your second task. And there'd been some earlier studies just of a couple of people who didn't have Parkinson's disease but were balance impaired, and showed that variable priority training showed better improvements in dual tasking than fixed priority training. So we wanted to have a look at that in people with Parkinson's disease. So we got them walking up and down that corridor, doing a variety of added tasks. And we did some passes, so we did about 20 passes of each type of fixed priority. And so here, for the fixed priority, we're saying, okay, I want you to try and do as best you can on both your walking and answering the questions, to try and do both as to the best of your ability. So I want you concentrating equally on both. Then when we did variable priority blocks of training, so our first block might have been that we don't want them paying very much attention to the added task. So I'm going to ask you some questions, but I really want you to concentrate on taking big steps. Okay? So don't worry about my questions as much, but really concentrate on doing those big steps. Then the next pass, it might be going, okay, don't worry about your feet as much. I want you to get every answer right really fast. And so you get them concentrating on the second task. And then vice versa. So switching between the two. So that's a lot more difficult to switch your attentional set between the two. So if we had a look at that, so we looked at pre and post training and across a couple of different types of added tasks, and it didn't matter what the added task was. Both types of training showed an improvement from pre to post. So there was no difference between groups, but both groups showed a training effect. So when we had a look at what they were doing, so after every pass, we got them to say, well, how much they were concentrating on each one. So after every 15-metre pass, they had to write down, what percentage they were thinking of their cognitive task. So there was a fair bit of error in all of that. When we looked at the fixed priority, when we looked at the average error, it was around 11%. So we also looked at the actual errors and actual changes in gait performance, and it married up with this. So they showed some error when they were doing the fixed priority training. The variable priority training, however, showed a lot more error. So what we found that people were doing was that in particular when they were told to not concentrate on their cognitive task, they couldn't really do it. So they couldn't go back and concentrate on their walking. They really felt that they were concentrating more on their second task. So they found it, it's part of their sort of response inhibition, so they found it difficult to not attend to the second task. So one of the findings here then is really they weren't doing what we asked them to do. They weren't really shifting their set that well to the extent that we wanted them to, because they had, so this is showing how much error they had. So the error when they were meant to be thinking of their cognitive task, of their gait task, was quite high. So we basically felt that, so that's quite hard for people with Parkinson's disease. So it might be where you end up in training as a very challenging task, but particularly early on, despite these balance impaired older people finding that that showed an improvement in their dual tasking ability, for people with Parkinson's disease, that might be a bit too difficult for them. So with a couple of those studies under our belt, we had a look at training dual tasking in people with Parkinson's disease as part of an overall package or program. And in particular, could it improve their ability to dual task when walking, but also does it have greater impacts broader than that? So does it improve or increase their levels of free living activity or their community walking? And comparing that to single task training. So we did a randomised controlled trial of people with Parkinson's disease who were idiopathic. They had to be able to walk relatively well. So 100 metres, they could use gait aids, and so several people did use gait aids to be able to do that level of training. They were stage 1 to 3 on HONNER, and they reported reduced step length, which we confirmed on our examination. So our primary outcome measure was just looking at their average step length. So we're concentrating on step length, so taking a large step when walking over a gait right map while doing added second tasks, and in particular words beginning with a certain letter. And we looked at them a couple of baseline pre's, a post, and then at 6 months as a follow-up. I'll talk about the measures, then the intervention. So then our community walking, we had a look at community walking with an active PAL, which is a device that measures the time spent sitting, standing and walking, worn for 3 days on the thigh. And we had a trip diary that sort of validated that. And we had a number of other types of measures that we could look at. We validated the active PAL device, both with looking at it in community and a longer walk. And so this is just showing a low average percent error. So all that's saying is when we did an outdoor, because we wanted to make sure that we're still detecting steps in people with Parkinson's disease who might have taken smaller, more shuffling steps, particularly when they're outside where they had to do things like be on a cross footpath, go through doorways, turn, a variety of things. So it was still, we compared that to direct observation. Someone standing beside them, as you can see there, measuring it, and someone calculating every step by just observation, and showed that there was a very low error. So we were confident in using this device. So the training we did, so we did 12 sessions for an hour per session, 3 times a week for 4 weeks, plus they had a home program. So they came to pretty much it was a hospital site, so it was done sort of in a physio gym and in around the hospital area. There was a physiotherapist who was providing the training, and it occurred during their on medication time. So on average around an hour after they've had their medication, but it depended on the individual. So we did single and dual task training. So the single task training on its own just did concentrate on improving stride length. So we wanted to improve people's awareness of their step size, and then we did a lot of progressions, which I'll talk more about towards the end. So progressing to things like stopping, starting, moderating their speed, environmental challenges, increasing the variety of their and frequency of their gait demands. So we did quite intense single task gait training to try and increase their step length when walking, and going from using whatever, if they needed any cueing strategies, using those, but then progressing to just more challenging gait tasks. With our dual task training, we initially concentrated on improving stride length, and then when it repeatedly achieved levels that were what we were hoping for, given their age and their height, we started with the easiest added task type depending on what we found on our assessment. So then we progressed both the gait task and the cognitive task to try and increase the challenge over time. We challenged them by both very specific added tasks as well as moving to very functional added tasks. And so they started from things like just listening, and so then at the end of a pass they had to answer questions about what they just heard, to a monologue, so asking them to say something as we're going along. So we'd ask them a question, to then having a conversation where we'd have to back and forth again as they're going along. To then, depending on what they found most difficult, whether they were words type of tasks, which were things like generating lists as an example, calculation tasks, motor tasks, visuospatial planning tasks. So towards the end we had, so this is just in a hospital corridor, which we end up taking over one corridor, as you do. Having said that, it was something that people quite like going down the corridor going, oh, let's do this. So in the end, she had to negotiate a number of obstacles. So here she's having to do calculations in her head about what she's going to buy at the shops, and she's got money in her pockets, and so she's having to get out the right amount of money by the right time. So the person here is sort of saying, okay, I want you to buy a bottle of milk at $3.50. It's not that expensive, let me just say. $2, that's just too easy. But this and this, and so she had to add it up, get the money out and do it by the time that she got to the end. So she had to do a calculation task as she was negotiating and getting things out of her pockets. So we initially looked at a lot of people to see if they would be suitable. A lot of them just didn't meet the inclusion criteria. And ultimately, we looked at 31 people in each group. On average, they're around 66 years of age, and most were Hohen and Yahr stage 2. If we have a look at what we did in training, we pushed them pretty hard. So we did a lot of measurements of what we did in training. So if we looked at the time they were actually active during the 60 minutes, so on average, it was 54 minutes that they were active over the entire time. The first session was definitely a lot less because there was a lot more instruction and discussion in that first session. But it's just sort of showing both the dual and the single did a lot of physical activity, and so that's one thing I think to highlight, is that you can probably push people more than what you think you can. The rest time was quite low, and they walked on average 1 kilometre during training. So they did quite a lot of walking during our training. When we had a look at changes from pre to post, so our dual task is in red, we found that there was a training effect and a group by training interaction. So basically, the single task group improved by about 4 centimetres in their step length, and our dual task improved by almost 10 centimetres in their step length. And this persisted in the dual task group, but it didn't in our single task group. If we have a look at velocity, there were some similar changes that both improved over time, so there was a training effect and a group by training interaction as well. If we have a look at our 6-minute walk test, so we looked at people walking, just your usual 6-minute walk test, again, this time both groups showed something very similar, so they both improved to a similar degree. And then when we had a 3-minute conversation, so this was a 3-minute walk while they were having a conversation, probably the key differences are, well, they both improved, but if we compare the dual tasking, they didn't drop down as much as the single tasking. So the dual tasking still were different from baseline, whereas the single tasking returned to baseline levels. So we found that both single and dual tasking groups improved in the ability to dual task when walking, and we were thinking that we might find a greater effect in our dual task group, but both groups did show some improvement. So some things for us to consider might have been, well, was our measurement task too simple? Because we got some dual tasking people doing some really complex tasks, and our assessment that we did was possibly not as challenging. So we might not have been able to detect the changes that we found. We're interested in the impact on community walking and whether we could find any subgroups that had greatest improvement, and also looking at cognitive changes. So if we have a look at cognitive changes, so we know that in Parkinson's disease, people have difficulty with their attention and their executive function, so which is things like shifting their attentional set, their divided attention, and inhibiting responses. And so there are a number of different tests that you can do clinically to have a look at that. And previous studies had found that, say, ability on the trail making test, which indicates, amongst other things, set shifting, it accounted for differences that people found when people were dual tasking. Similarly, executive function, another element, well, which you can have a look in a number of ways, but this one in terms of looking at set shifting, also associated with gait speed and variability under dual task conditions. So we actually did have a neuropsychologist who did a number of measures of cognitive function, particularly executive function at baseline, and wanted to see how that whether that was associated with changes in dual tasking over time. So some of the key measures that we looked at were the trail making test. So this is one where you've got an A test and a B. An A test is just going, join the dots, 1, 2, 3, 4. B is you have to go 1A, 2B. So shifting set between thinking of sequentially numbers to sequentially letters. And so often it's the difference between your performance on B minus A, which shows your ability to shift set. Colour word interference, I'm sure you've seen this one before with the Stroop test, where firstly they just have to say out loud what they're seeing. So the colour is congruent with the word, and then you have sets where you have to say what the word is, not what the colour is. So the next line, what would you say here? What's the word, not the colour? Green, red, green, blue, red. But when you're seeing the word green written in red, that can be confusing. Another one we had was a test of everyday attention. So this is one which is looking at the ability to attend, so sustain your attention, and also deal with distractors. So here they had to, this is a telephone search, find all repair shops with the area code this, so a complex number, and then they had to go down and find, okay, this is a symbol for a repair shop. So you had to find the code and that matching up, and then remember the number that you're at and go to the next one, and so in the end come up with a number. And then every now and then there'd be a loud noise that would distract you, and so that's the quite nasty things these neuropsychologists come up with. And then another test, Haling and Brixton, so which has a couple of different components, one of which is getting you to inhibit a natural response. So it might be something like red, white, and you think of what would be the natural response that you would say. You've got to not say your natural response, so you can't say blue, so you've got to say red, white, and purple. And so they look at the time it takes for you to give that response and number of errors. So they want you to inhibit what would naturally come to you. So, pretty nasty looking lot of numbers here, but basically the ones highlighted are the ones that we found most association between improvements in dual tasking and these cognitive measures. So our trail making test, so the difference between their ability to do 1A, 2B and just the 1, 2, 3, 4, that was the most highly correlated with improvements in dual tasking. We found a few in Stroop. Again, it relates to their errors, the telephone search time, and this is one of those inhibition scores. So essentially, we found those who had a greater improvement in dual task step length with training had the poorer executive function. So those who had greatest potential to improve did improve. So that was the cognitive function. If we switch then and look at, well, what do people actually do in terms of their community mobility afterwards? We looked at the number of steps people took in the community. So we basically found no difference between groups. So the single task group dropped slightly in the number of steps they took in the community, and our dual task group increased by about 700. So between the two groups, there was a difference of about 1,000 steps, but it wasn't different because there's quite a lot of variability between people in groups. Similarly, if we look at the time spent walking or stepping in the community, you found something similar. So there was a slight drop in the single task group, a slight increase in the dual task group, with the difference being around 11 minutes between the two. If, when we talk about subgroups, we then looked at those who weren't very active at all beforehand. So those people who were doing less than 4,000 steps a day at the baseline. And then when we had a look at those, the single task group pretty much stayed the same when there were people who didn't do very much. But the dual task group increased by almost 1,500 steps, which when they're starting at a low level, at about 2,500, potentially that might be clinically important. So another thing that we did look at was their diary data, because we have these active pals and you get numbers out of them, but maybe that's not explaining everything. And we did find some interesting information. For example, we had some people like this person, participant number 44, where their volumes of activity stayed the same, but what they actually did, so the complexity of their task modified. So this person had said, I'm now back to bell ringing, which I'd given up because of my Parkinson's. It was too hard to think, move quickly and pull the bells and get it right. I'm back to doing it 4 times a week. So this is someone who went to their church, and he told me all about it, but you know, you have to pull different levers and do steps at the same time to get things going, you know, to get a nice tune out of these bells. So he still went to church as often, but he did more complex tasks when he went there. Rather than just sitting there and not participating, he now was feeling happy that he could do more complex tasks at the same time. So we didn't find any statistical difference between the two groups in their volume of community walking, but potentially some of these measures may be clinically important to improve by over 1,000 steps and by 11 minutes. And those who did little community walking at baseline increased by about 60% more than the single task. So maybe there's some people to try and concentrate on and target those who say they're not getting out and about very much. So the gains, however, that we found weren't maintained at 6 months, which, you know, is not surprising because that's often what happens. And so it's interesting to say, well, how can we sustain change? And I think we need to find challenging dual task interventions that people can participate in for a longer term and can be progressed over time. And so that's where we've been working with a ballet company in our town who have implemented what they call Dance for Parkinson's, which was developed from New York with a dance company over there, and they train a small subset of dancers to learn about Parkinson's disease and help to devise exercise sessions or ballet sessions for people with Parkinson's disease. So we ran a Dance for Parkinson's session in Brisbane. So it ran for 6 months. And so we looked at people's changes in their motor ability, in their balance and gait, pre and post, and also looked qualitatively about how it affected their lives. We only had a small number of participants, but when we looked at their dual tasking pre and post, we did find an improvement in their doing a dual task, so their tug with words, with a mean improvement of about 2.5 seconds post the dancing. So that was pretty good because they only did this once a week, which I was a bit sceptical that once a week for an hour would really make that much difference. But it did seem to make a difference. In terms of, let's see, yep, somehow it's got out of order. Qualitatively, what we found was people found that it made a big change. They said a big change physically. They felt that they moved in a different manner. Our objective tests, a lot of our balance tests didn't really detect any changes, but they felt that they were moving differently. Emotionally and cognitively, they felt that it made a big improvement to them. They had, socially, it got them out and about more, and they felt that it gave them an artistic outlet. And importantly, what sort of came out of this is out of our qualitative discussions with them, was that it seemed to be a gateway activity. So in doing this, it then gave them the confidence to then try other things as well. So they had more confidence in their ability to get out and about. So I go back. So other things that we've been looking at is, so with the community walking, not just the volume of walking, but trying to measure, where they're going and what they're doing. And what we talk about here is life space. So we've begun to look at this with some large data sets of people's mobile phone data to have a look and see, because what we're interested in, the idea of life space is that it's looking at where you're going and what you're doing, rather than just the accelerometer isn't giving that information about where you're going and how far you're travelling. So we ended up looking at some data that was supplied as part of a large data set, just to have a look at whether our algorithms would work. And so what we're looking at here is, this is sort of a person, and this is showing, the red is most time spent, but it's showing how far out people go. And so it's a lot of data and information, but there's lots of things you can get out of that, whether it's things like the number of trips, how far they're travelling, how frequently they're travelling. And so even just looking at some basics, if we look at, these are the names that we've given people just to de-identify, those who are less impaired, down the bottom, have less time spent at home when we look at where they're going with their smartphone. So it's one direction that we're going in. So seeing what we can detect from things like, big smartphone data, to try and use that to try and capture changes in what people are doing, because it's something that people may have with them, rather than going away with an accelerometer, which isn't, it's quite a researchy type of device. So it might be able to link in with different types of databases. So then ultimately, there are several groups around the world looking at this, where we see if we can collect some of that data in a cloud, and then that gets shot to the clinicians, who can then detect what people are doing. Are they reducing what they're doing over time? So that's ultimately the big picture of what we're looking at there. This next one, where we've looked at seeing if we can enhance dual tasking in other ways, because yes, we found an improvement, but it wasn't massive. So this is a device, transcranial direct current stimulation, which is increasing in its use in the research literature, particularly in stroke. So what it's aiming to do is it's just aiming to increase the excitability of neurons over the areas where it's placed, which makes them easier for them to depolarize. So they're saying theoretically with Parkinson's disease, if you have reduced cortical drive coming from reduced drive from thalamocortical loops, then it doesn't take as much drive to get the motor signal happening if you're putting it over M1. And so there have been a few studies prior to what we've done that had shown that using that over M1 in conjunction just with normal gait training, they could improve step length and velocity in people with Parkinson's more than just gait training alone. So we decided to use it while they were doing their second task training at the same time. And so this was using a similar protocol as what we've done before. And what we found was that we actually didn't find, so there were two groups. They were randomised to either a getting it for real or a sham group, where they didn't know if it was working or not, and the trainer didn't know if it was working or not. And so when we compared the two groups, both groups again showed an improvement in their gait performance to a similar degree, but the group who had it on, so the active group, actually showed when they were dual tasking, they could do their second task better. So they could do more responses, for example. And so one thought behind that might be that they had been able to make the gait a bit more automatic, which allowed them to, devote more cognitive resources to a second task. So that's just one study that we've just recently published, but it's one direction, just seeing if we can do other things to enhance our dual task training. So I thought I'd sort of end with some clinical sort of ideas or implications, or to talk about practical applications, which this isn't the be all and end all, but this is sort of things that we've learned from what we've done. In terms of, who to train with dual tasking in terms of Parkinson's disease, we've really just looked at people with idiopathic Parkinson's. We could have a look at other groups, but that's what really we have been looking at. Generally, you're wanting to have people who do need to show some improvements. So whether it's under single and or dual task conditions. So often we would have people who would call up and say, I want to be involved, but I think I'm too good for you. So when we come in, we do find maybe their gait isn't too reduced under single task conditions, but when we give them a second task, their gait does deteriorate. So it shows that they do have potential to improve. If you had someone who, on giving them a second task, they're really showing no deficits, well, there's not as much to improve there. Clearly need to have the cardiovascular ability to train. So with what we've done, we've tended to use, you don't have to use large chunks of time, but we have tended to use, a good hour-long session of one-on-one. So it does mean that we're working people relatively hard. Cognitively able to train. So what we found was a MMSE of greater than 24 was what was needed. If you had less than that, people really did find it difficult to grasp what it was that they were meant to be doing. So clearly it's not going to be for the more end stage person. So it's someone who's still relatively cognitively intact. Possibly you might find best effects in those who you already know have executive function problems, particularly set shifting. Potentially you don't regularly have trial making tests undertaken by you or a neuropsychologist. I mean, we tend to have our neuropsychologists do these tests, but I wouldn't say that it's necessary that you have to do that. And consider people who have freezing of gait. So people with freezing of gait do tend to have more deficits in dual tasking. So I wouldn't say don't do them or definitely do them. Have a look at them and see if you think. Often they may be more advanced and may have also other issues going on as well. So it'd be important to have a look at those. In terms of medication, train in their on period. We found that on talking to people, they often didn't really have a good idea of what an off period was. They go, oh no, I don't have an off period. So we tend to say, well, go fishing for what they understand is an off period. So how are you lasting at night? What are you like first thing in the morning? And so often they will discuss things, and they won't think that they're off, but they say, oh yes, no, I'm foggy in the head. wide, we're a bit slower. And we go, well, for you, that is potentially being, off. You're not at your optimal. So sometimes we found it was important, we had quite a lot of people who didn't realise that they had some fluctuations there. So I think that's important to note. And so, what we talk about, well, that's what's off for you, because it varies by person. So some people will notice motor changes, but others, it might be just they feel foggy in the head. Train in the on time. So we haven't done any training in the off period. Firstly, just for safety's sake, you probably want to be training in the on period, but also their ability to do a second task is likely to be better when they're, in their on period as well. You could try some more in the off period when they're more practiced. We didn't end up doing that, but you could have a look at that. And watch when they do it around meal times. So, in terms of looking at our principles of skill acquisition, I'll go through each of these. So we did one-on-one training to allow focused attention, but you don't need to do one-on-one training. You could do this in a group. Certainly with our one-on-one training, our trainer really improved their dual tasking, because you're trying to think of the next task of what they're doing, as well as monitoring what they're doing. For us, they were measuring, so it needed quite a lot. We found that you really needed to have some ideas written down there. Otherwise, you're the one who's multitasking. Okay, what am I going to do next? So we had lots of sheets with ideas written out, so people could quite easily progress from one to the next. As you can expect with focusing attention, start where it's quiet, with a high concentration on the task, and move to a more distracting environment. So we often started in the gym in a quiet time period and then moved out to corridors when there were people moving around, people coming in and out, etc. With our single task training, we tried to improve their step length using whatever strategy worked for that person, if they required that just for single task training. So if they needed some form of strategy training of verbal, visual or auditory, but we tried to internalise those cues as quickly as possible. So to think of big steps, or to think of stepping over, or think of a beat, so that we didn't have to have a second external task. What we tended to use was the thought of big step, or saying big steps, and trying to get people to increase their awareness of step size. So people often thought that they were taking a big step. It's like the loud, speaking loud. They think they're speaking loud, but they're really not. So that difficulty in modulating size or amplitude. So we often got them taking much larger steps than what they needed to. So doing really big steps so they could see what it was like. Now this is a really big step. And concentrate on what it feels like, and watch other people walk and have a look at their step size. In terms of our progression, I think I mentioned a lot of these before. Structured environmental demands, turns, all the things I think that you do anyway in your therapy sessions. And that's just shows a few things with gym setups. So both looking at step height as well as length, and a variety of things. Feedback. Thought that external feedback was important, so depending on the person, but often having mirrors. So we had some sections of the gym where they had mirrors, where for some people it was really important for them to concentrate on, so they got that external feedback of how large a step they were doing. When we looked at the second tasks, we used both cognitive and motor. Started easy, progressed to more complex tasks. When they focused their attention, we needed them to change their awareness of what they were attending to. So often they didn't think what they were attending to. So when we got to say, okay, so what were you thinking of there? How much of you were you thinking of your walking, or how much were you thinking of your second task? So they're often not aware of what they're thinking, and if what we're wanting them to do is to think of taking big steps.
it often helps to really say, okay, what were you thinking of there? So it's training them to be more aware of what they're actually thinking about. So conscious decision to try and focus in a certain manner. In terms of what we're looking at when we're detecting, probably one big thing that we picked up because we're dual tasking and looking at our folders and other things was that you often hear the change in their steps rather than just needing to see them. So whether they're not landing with as much force, whether they're landing with their toe and not their heel, and also their speech changes when they're doing their second task. We can tell when they're dropping down because they might become a bit softer, and their cognitive tasks might slow. So it's something that you might not think of, that in what you're hearing, it's not just looking at the patient in what they're doing. Clearly, you want to have a look at what they're doing as to whether their gait is changing, but it's the hearing. I think I mentioned that. So where do you start? So what we did was timed up and go tests with motor and cognitive tasks. And we started with the easiest task type. So we just divided them into 3 different types. So a motor task, a cognitive, which was words, or a cognitive, which was count. And so say here, we'd start with a motor task first because it was fastest, then the counting, then the words task. Motor tasks can go from simple to more complex, so unilateral to bilateral. Simple, which could be carrying, to more complex, which might be more manipulating, as you can see there. And then, moving to more functional motor tasks, so negotiating with doors, going over uneven surfaces, dealing with speed and crossing roads. With the cognitive tasks, so we sort of had a big set of a large number of different types of tasks, but some ideas for some sort of things that you could do in terms of, say, if it was more of a maths type of thing that they found was easier. We had a whole list of different things. So easy things like, as you're walking along, what's 5 by 6? Answer, so you're back and forth. Things like digits forward or backwards. So I say the number, so 87,571. So say the digits backwards, so 17578. So you start with easy things and you can go forwards and then move to backwards. Language, do things like, matching, noun and a verb, noun and a noun. Verbal suppression, sort of similar to that other task. So the bride wore, can't say white, got to say something else. Visuospatial, so as you're walking along, so okay, tell me how you get from physio back to the front desk. And so as they're walking along, they have to tell you if they turn right, left, if they hop in the lift, where they go. So they're thinking about a visuospatial task as they're going along, or a visual discrimination task. In terms of prioritising, we started with equal priority between tasks and can progress to variable. Generally, we did it in at least 5-minute blocks because otherwise it's a bit too much back and forth to be too difficult. How much do you do? Well, this is really based on what we had done. We did 3 times a week. We introduced a home program as soon as possible, trying to make people to take a walk, and indoor and outdoor, and trying to dual task when they were outside. So things like, so it depended on the person, and this wasn't the first thing you got them doing. So we got them going outside, and so thinking of the different things that they could do to dual task, and when they're out there, whether it's counting things, counting the number of trees as they're walking along, looking at a sign and thinking of words beginning with the letters in the words of the sign, those sorts of things. And clearly, you need some accountability when they're doing second tasks. So, key points overall, people with Parkinson's disease do tend to have problems doing an additional task when walking. It's important to assess dual tasking when walking, and interventions. Think to progress your balance and gait programs to include dual task activities that are tailored to the individual and their goals. And it looks like that people with Parkinson's disease can improve their ability to dual tasking. Overall, we want to also ask people about their community walking and find out what makes it difficult and easy, and assess their ability to dual task when walking and consider modifying their walking training. So there you go. All right, that'll do.